We're going to get you a cough drop. Sorry. It's okay. It's that time of year. Senator Moning's up here coughing too, so we'll work it out. We'll now move on. Senator Moning, any questions before we move on? We're going to move on to number 7, Medi-Cal annual open enrollment period, page 33 of the agenda.
Sure. So just briefly, this proposal would establish an annual open enrollment period for health plans process for non-disabled family and child Medi-Cal managed care plan beneficiaries who are mandatorily enrolled in counties with more than one Medi-Cal managed care plan. Beneficiaries subject to this would be allowed to change plans only during the open enrollment period with exceptions as noted in the agenda. This period would occur every year and coincide with the open enrollment period of Covered California. There are benefits to having stable enrollment. It helps ensure continuity of care and case management, and it helps improve monitoring and oversight of health plans since many quality metrics are measured only for those populations who've been continuously enrolled in the plan. And so with that, I'm happy to take questions.
Anything, Senator Moning? Finance or LAO? LAO.
Amber DG, Legislative Analyst Office. We find that the proposal has potential benefits. For example, an open enrollment period could create administrative efficiencies, as well as opportunities for outreach to beneficiaries regarding plan selection. We also find that less frequent plan changes may improve measurement of managed care plan accountability, as discussed by the department, because quality of plans, for example, can only be measured for beneficiaries that are enrolled in the plan for several months continuously. While we recognize the proposal would limit beneficiaries' options as to when they could change plans, on balance, we recommend approving the proposal given the potential benefits.
Thank you. Finance? Public comment? 1 minute, please.
Linda Way with Western Center on Law and Poverty. We oppose this measure and appreciate the legislature opposing similar measures in the past. We oppose this for a multitude of reasons, one being that Medi-Cal beneficiaries have always had the right to change their plans, and this is especially important considering that unlike their counterparts in Covered California who must select a plan, Medi-Cal beneficiaries can be defaulted into a plan. Secondly, even though only parents and children are included in this plan, there's a long list of exemptions which make it cumbersome to implement as well as very confusing to the consumer. Adding to the confusion for consumers is that they can apply for Medi-Cal throughout the year, and so we'll have to keep track of 2 different dates, their redetermination date as well as their open enrollment period, and so we oppose this measure.
Thank you very much. Next witness.
Thank you, Madam Chair and members. Nick Luizos on behalf of the California Association of Health Plans. We're supportive of this proposal. The underpinnings of this are really continuity of care and a logical inflow of new members into the Medi-Cal managed care system. We think that while it's held open, it should be given careful review. It has been denied in years past, but we should mention that the department this year did exclude some populations, many of which are going to be new to managed care, and they sought to model it after systems that other enrollees partake in other aspects of the health system. So we think those should be taken into consideration favorably as this is held open. Thank you.
Thank you. Next witness.
Thank you, Madam Chair. Eduardo Martinez, California Medical Association. We are also in opposition to this proposal. We've been opposed to it in the past. The last conversation about rates is illustrative in this particular proposal. Some of our providers contract with various managed care plans to provide care to Medi-Cal beneficiaries. Some of those plans are deciding to pass along some of the rate cuts that have been enacted over the past few years. Some of them are not. There may be a situation where perhaps a provider can no longer participate in a given plan, has been seeing a patient for quite some time, has to decline participation in that plan anymore, but is still going to participate in another plan, perhaps is not passing along those cuts. This bill or this proposal would eliminate that opportunity for that patient to remain with that same provider. In fact, to some extent, that kind of undermines the whole continuity of care sort of general construct there. So we would urge your opposition to this proposal.
Thank you very much. Next witness.
Tam Ma with Health Access California. We continue to be opposed to requiring open enrollment in Medi-Cal managed care plans. There are some critical differences between medical managed care and their commercial managed care counterparts that make mandatory open enrollment inappropriate. In addition to folks being enrolled into a plan by default and not knowing that right away, Medi-Cal managed care plans have lower quality ratings in general, and folks should have the option to change plans if they feel like they could get better care elsewhere. In addition, although the trailer bill language and federal regulations allow folks to change plans for cause, we are concerned that this process places a major burden on beneficiaries to go through all of these different hoops and hurdles to do that. And this is something that would be very challenging for just the average consumer, but especially so for Medi-Cal beneficiaries. And finally, just like my colleague at the Western Center stated, this proposal does exempt a large proportion of the Medi-Cal population, but again, most folks don't know, what their aid code is or how they got into Medi-Cal, and we're concerned that this will just create more confusion than it's worth, especially given the very small savings, if any, that will result from this change. Thank you.
Thank you. Next witness.
Hi, David Thompson with the Dental Surgery Centers again, and I would like to say that we would oppose any legislation like this because as a specialty provider and with all these managed care plans coming into California, there's a large number of them. The net benefits they are providing, the beneficiaries are different. The policies set forth by the state are being enacted in different ways by different plans, and so since the benefits are so fragmented, sometimes the beneficiaries cannot get the services that are guaranteed to them within one health plan, so we ask them to switch to a different health plan, which they will. Something like this would eliminate that possibility, and these are kids with faces that are swollen that need emergent care, and so we can't have anything like this without better oversight of the managed care plans. That's a different story. Thank you.
Thank you. Next witness, final witness.
Katie Truworthy with Anthem Blue Cross. We actually are in support of this proposal, and I guess I would just say if there are problems with the health plan not providing care, we would hope that that would be a discussion to be had with the health plan. We do appreciate the administration creating a much more modest approach to really look at this and figure out a way to make it work, and we look forward to working with the advocates for a solution. Thank you.
Thank you very much. As it was stated by several comments from members of the public, it is an issue that the legislature has denied in year past, but today's recommendation is to hold the item open. We'll move on now to item number 8.
Great.
MCO tax.
All right, so the governor's budget does propose to replace the existing Medi-Cal managed care organization tax with a broad-based MCO tax that would satisfy the requirements of federal guidance that was issued last July. The guidance indicated that the current MCO tax is essentially likely impermissible under federal Medicaid regulations and after its expiration in June 30th, 2016, because it only applies to Medi-Cal plans and federal regulations require healthcare-related taxes to apply to a broader class of providers. The new broad-based MCO tax would apply broadly across plans that are regulated by the Department of Managed Healthcare and/or our Department of Healthcare Services. The proposed tax is a tiered tax based on levels of enrollment, and it excludes Medicare enrollees as those that's impermissible to tax Medicare and Medicare Advantage enrollment, as well as excluding plan-to-plan enrollees so that this single enrollee isn't being taxed in both plans, that it's if there's a subcontracting relationship. This tax is also being proposed as is required under the settlement on the IHSS reduction to restore the 7% reduction in hours. And so the total funding that is being sought is about $1.35 billion to replace the existing tax and to fund the offset of the 7% reduction. In terms of our discussions with the health plans, we have been in discussions with them. As we've indicated from the beginning, we tried to develop a proposal that met the federal requirements, met the funding requirements that we needed, and tried to limit the overall net impact to health plans. This isn't something that we specifically wanted to have to propose. Obviously, the federal guidance forced our hand into changing the tax that we have now. And so we tried to come up with a proposal that would have as small of an impact as possible on health plans, but recognizing that at the end of the day, a broad-based tax was going to have a net financial impact. We are open, and we've indicated to the health plans, to looking at other models that still meet the federal requirements and meet the funding requirements, and have offered our technical assistance to them as looking at other initiatives. And certainly the plans have indicated they would be taking us up on that, and we anticipate further conversations with them over the next several weeks. And then I know there was a question specifically about legal risks to the state, so I will turn to my Department of Finance colleagues for that.
Thank you. Thank you, Madam Chair. Scott Oakes with the Department of Finance. As far as the legal risks are concerned, the administration believes it's fulfilled the obligations under the Oster versus Lightbourne settlement. The settlement requires the administration to submit a proposal to the legislature that restores the 7% IHSS reduction with a provider tax, and that's the proposal before the committee today. The settlement also requires the administration to submit the proposal to the federal government by April 1st, if the legislature approves the proposal by that date. Thank you.
Just to circle back, did you give us any kind of time frame for the discussions with the plans?
So, sure. So I said the next several weeks
Okay.
is what I said.
That's fine.
Yeah, that's okay. I know you want more specific time frames from me.
Thank you. That's how I can come back and double check. Senator Bonnie? LEO?
Thank you, Madam Chair. I just wanted to point out a couple of things. The structure of the administration's proposed MCO tax is quite different from the current MCO tax in ways that Ms. Cantwell very adequately described. Mainly, the tax is designed to comply with federal rules while trying to preserve the amount of funding that's raised under the existing tax. And that means the tax has to be broad-based, meaning that it won't just be assessed on medical and managed care, but also on health plans' commercial lines of business. And that's the main takeaway from our analysis in the budget, which is that you really have to think about this as a tax that functions as an actual tax on commercial coverage that results in a net financial loss to the plans that are paying the tax. And we think it's likely that the plans will pass on some, if not all, of this tax eventually to employers and individuals that purchase commercial coverage, including CalPERS. Now, we don't necessarily think that this is a large cost relatively for the state budget, probably something in the range of tens of millions annually for state worker and retiree health benefits, but we do think that the effect will be there. The other issue to point out is that there are certain health plans that would face a high proportionate tax bill, but because they don't do much Medi-Cal, they would not be able to receive an offsetting payment from the state in terms of a higher Medi-Cal payment. All that being said, we do recognize that it's important to seek a general fund replacement for the $1.1 billion that the current tax achieves, as well as a funding source for the IHSS 7% restoration as required under the legal settlement. And we do find that on balance, the governor's overall concept for the new MCO tax, despite its unequal treatment of different plans and the likelihood that at least some of it gets borne by consumers in the long run, is a reasonable way to try to pursue this revenue, especially because under the proposal, the federal government would still fund more than half of the $1.3 billion that's eventually raised. Now, we don't think the legislature should necessarily feel particularly rushed to pass a tax by the end of this month, say. In fact, we'd advise against trying to pass a tax so hastily because it doesn't leave nearly enough time to properly vet the proposal. And what the IHSS settlement actually says is that if the tax is not submitted to the federal government for approval by April 1st, then the state and the plaintiffs can go back to the table and work out a resolution. And only if a resolution is not reached can one of the parties go back to the district court potentially to seek a remedy. Now, we're not parties to the settlement, but we think a potential resolution could be pretty straightforward. It could simply specify that the tax need to be passed by the end of August for it to be submitted to CMS by September in order for the tax to be operative through 15-16. We also want to point out that the administration's draft language suggests that the tax wouldn't be collected until December 1st, 2015 at the earliest. So we don't think there's a compelling reason to feel rushed to get the tax out the door by April 1st. We do think that you should enact a tax by the end of August and that it should be in place for at least several years under the authorizing language in order to aid better budget planning and predictability. Now, what would 5 additional months of deliberating the tax really buy you in terms of passing the tax in August versus April? Well, we do think that the proposal's details could use some work. The proposal in particular in the draft language is particularly vague about how the tax would operate and be administered on an ongoing basis. And for those reasons, we do not recommend permanently authorizing the tax in its current form. Whether or not the legislature ultimately decides to permanently authorize a tax structure, we think there's room for improvement in the language. For instance, the legislature could specify the tax tiers and the amounts on a multi-year basis rather than just 1 year, so that the state can have a sense of what revenues are coming in, the plans would know what they're paying, and we'd only have to go through the process of federal approval once as opposed to every single year. Finally, I want to circle back to my comments that there are some health plans that would face a disproportionate burden of the tax, and there are many workers and families that rely on these health plans for coverage. So we think you should ask the administration more about the distributional consequences of the tax. Thank you.
Very helpful, thank you. Senator Monning? No, but that's very helpful. It was. We'll open it up to for public comment. 1 minute, please.
Thank you, Madam Chair and members. Nick Luizos on behalf of the California Association of Health Plans. We represent 43 Knox-Keene licensed health plans in the state, many of which participate in the Medi-Cal program, many others that provide commercial coverage for employees and individuals. As the department stated, we have had some initial conversations with the administration on whether an alternative to their MCO tax proposal can be achieved. While our trade association has supported previous iterations of the MCO tax, it's very safe to say that there is no consensus on the administration's proposal within our industry, and indeed certain elements of our health plan community are in opposition. However, we are committed to exploring alternatives to replace the existing tax. We do understand that we are in this situation because of federal intervention, apparently which requires a much broader application to any Medicaid provider tax, whether it applies to a provider, a plan, or to any other healthcare entity. We do believe the federal government's letter on the issue gives us more time, and this is very important to figure this out if possible, even until the end of our 2-year legislative session. In the meantime, the existing MCO tax structure remains in effect, which is important because at least in the budget year, there is no fiscal impact to the state in not taking immediate action. We believe it's important to take advantage of this time because as addressed in some of the testimony already, that a hasty solution could lead to some drastic market impacts. So under the principle that we have more time, we will continue discussions with the administration to determine whether an alternate exists that directly benefits the Medi-Cal program, is equitable to the payers of the tax, and considers affordability to the purchasers of health care. So thank you for your time.
Thank you. Next witness, please.
Katie Truworthy with Anthem Blue Cross. We are one of the state's largest players in both the Medicaid and the commercial side, so we obviously have a very vested interest in this. Obviously, on the Medicaid side, we're very supportive. However, the current proposal, MCO proposal, has a significant impact on our commercial side, and we do look forward to working with the administration to find a better solution, and we would urge the committee to hold this open until such a resolution can be found. Thank you.
Next witness.
Thank you, Mira Morton here on behalf of the California Chamber of Commerce, and we are in opposition to this measure as currently proposed. I do want to say we're very sympathetic and understanding of the pressure and the importance of making sure that Medi-Cal is properly funded going forward, and for that reason, we are actively going to be working with plans and with the administration to see if we can come to a better resolution. Our opposition is based on the impact that this proposal will have on premiums, which we believe, we're trying to address access issues in the Medi-Cal program, but we don't want to create access issues in the commercial sector by shifting costs from one sector to the other. And so for that reason, we would urge the committee to hold this measure open, and we will continue to work with everyone to find a more appropriate solution. Thank you.
Thank you. Appreciate it. Next witness, 1 minute.
Sorry. Chair and members, Kathy Mossberg representing the local health plans of California. So we are obviously a large player in the Medi-Cal side of things. And we have a great vested interest as highlighted by Ms. Truworthy on their Medi-Cal side. And so we have partaken in some of the conversations with the department. We'll continue to do so. Appreciate the suggested action for the committee today to hold this item open to allow for time for those conversations. Thank you.
Thank you. Next witness, 1 minute, please.
My name is Ernie Spencer from Solano County. I'm here to ask you to restore the 7% cut on in-home support service.
Thank you, ma'am. You can do it. Tell me your name.
Goodbye. Anybody?
What else?
Help.
We need help.
And B.
Please.
Thank you.
Thank you. All right. Thank you very much. Appreciate it. Next witness.
Hello, good afternoon. My name is Aisha Palmer Islam, and I am an in-home care worker from Solano County. I provide care for my brother who has stage 4 congestive heart failure and type 2 diabetes. I strongly support and hope that you would restore the 7% cuts for all in-home care workers. It would make a better quality of life for the recipient as well as the provider. Thank you so much for your time today.
Thank you very much.